slide is not about immunization. It tells the story of minimally invasive treatment of stone and how it has evolved over the years. And PCNL is the mainstay of miniaturization of treatment of stone. So that's the outline of my presentation. I have no disclosures. Based on my experience in my journey towards competence in minimal access treatment of stone, talking about PCNL now, I would define competence in PCNL as the ability to achieve a self-performing access into the pelvic healthcare system as many times as may be required at any point during a particular procedure using fluoroscopy, ultrasonography, or even laparoscopy, but preferably in various combinations, percutaneously, with additional capacity of complementary retrograde access, if necessary, with a view to achieving a decent clearance of kidney and or upper ureteric stone, either in prone position, but preferably in two. So it's a bit lengthy, but it's a test story of the competence of achieving competence in PCNL. From the definition, you will see that most PCNL surgeons are either prone or supine. Very few combine the two. And also, for the guidance of puncture and dilatation, most use fluoroscopy. Rarely do you find people who are able to combine the use of fluoroscopy, ultrasonography, and even laparoscopy when needed. So I liken PCNL to bar muscle up in gymnastics. People who are able to do bar muscle up at pro level in gymnastics, they are very few if you go to an average gym. So, and this mirror what you see in the practice of endourology. In Brazil, for instance, 72% of endourologists do PCNL. In US, 73%, and in Canada, 91%. And even worse still, in the US, less than 20% of practitioners of PCNL are able to do a self-performing access. So the issue of competence around PCNL revolves around depth perception. PCNL is about depth perception, and all you're going to do in trying to achieve competence in PCNL will be around depth perception. And this picture is just trying to depict the concept of depth perception. So my journey actually started in 2017 with AUA course from access to exit in PCNL, and this is one of the legends of our trade, Professor Ravi Clayman at University of California, Irvine, who actually, together with his right-hand man, Professor Jamie Ladman, organized the course, and I don't know whether they still do the course today, but it's a very, very important course where we were allowed hands-on, both in the trial lab and also on cadavers, to learn how to puncture the kidney and how to dilate in order to be able to do successful PCNL. So, and then thereafter, I've made several other trips to attend workshops, short trainings, and in the process, my path and some of the key opinion leaders around the world in the field of PCNL I've crossed. People like Professor Skipal, Professor Wazeng. The two people in this picture, Professor Lami from Germany and Dr. Amusawi from Kuwait, they kind of helped shaped and molded my preference for mini PCNL. So this Professor Leclerc from Morocco, who's a mentor. And in 2019, there came a major gap in my pursuit towards achieving competence with COVID. And Chairman Vadi, through the creation of Pure Neurology Group, came to the rescue with several online teachings where he brought major experts who helped to develop the educational programs of this area. So after all these several trips, the moment of truth came when I had to start the program. The major challenge I had was coming back to my country. There was no infrastructure. I came back to the hospital where there was no serum, there was no laser, there was no little. So it was a bit of a challenge. So I had to collaborate in a private setting with the hospital where they had some of these facilities. I got some, and then we collaborated, and that was how we started. But at which time, some of the skills I acquired were already getting rusty. So I developed this model of getting a foam. I impeded the stone inside the foam, and I put it on the operating table, strapped it with a plaster, and I started on my own to figure out how to target the stone. So in both bullseye technique, I was able to practice bullseye, rather the same technique that was displayed by Escape Power. And by the time I was successfully banging on the stone, I knew I was ready to move on to the human model. So and that was how we started in September 2022, and over the 3-year period from then till now, we've gone into 2 cases successfully, and with the age range of 17 to 98 years and male preponderance. So this is the distribution of the indication of the stone. We're able to do 11 stagom calculi, full stagom, I mean to say. Then we're able to do 16 partial stagom calculi, and then 23 lawful calculi. So my preference is mini PCNL. We did conventional PCNL in 11 cases. So the most commonly preferred patient positioning for supine was the flank-free oblique supine modified metotomic position, the first knee position, whereas the most preferred positioning for probe is split leg probe positioning that allows me to do retrograde access when necessary. So this is the distribution of the proctor guidance. Fluoroscopy is the most commonly used So based on our experience over these 3 years in the 82 cases, we were able to phase our competence into from phase 0 to 5. Phase 0 is when we did not have competence at all. Phase 1 was when we had doubtful competence. Phase 2 was some competence. Phase 3 was full competence. Phase 4 was expert level competence, and phase 5 was innovator level competence. And then this table depicts how at those various level of competencies we're able to achieve growth and improvement in the procedure, from the time to puncture, the number of cases, the spectrum of cases, the confidence level, and the success or failure of access, and the type of PCNL, and the puncture type. So it's instructive to note that at grade 1, we were spending between 1 hour to 3 hours before we could achieve access, which was discouragingly long, and this can explain why some people get discouraged with venturing into this procedure. But as of today, we usually take about 20 seconds to 4 minutes to puncture and to dilate and get access to the system. So, and from phase 1 to 3, I was usually doing biplanar puncture, and all procedures were done in Pro. But from phase 3 to 5, we were able to do complex procedures. We moved from Pro to supine, and we also moved to endoscopic combined intracranial surgery, which we were able to do in both Pro and in supine position. And most punctures were done in a monoplanar fashion. We rarely change CM. So this is the step for reinforcement position for supine position. And I just want to use a few cases to illustrate some of the procedures we did. So the first case was arguably one of the most difficult cases I did. And what you're seeing there is not RPG. That is canogram. So, and this is the RPG, looking like a Christmas tree. So it was a very difficult stone. And so in this patient, I did prone split leg positioning, and I had to do 6 punctures and tracts to be able to give this patient this kind of clearance. 3 of the punctures were supracostal, and it was a tubeless exit. And what I noticed was, at the point I was removing one of the supracostal amplar sheet, there was a bit of gush of air, and that suggested to me that there was possibility of formation of the pleura. So I was able to scan with the CM to see that there was hydrothorax, and then on the table we did a CTTD, and the patient did well. We just about additional idea or 2 of admission, we estimated, and the patient did well. The second case is a standard calculus in the left ectopic pelvic kidney. So what you see there is the scamogram, and this is the RPG. So in this patient, I did combine laparoscopic and fluoroscopic guidance to gain access, and dilated over the access, and then utilitoclast broke the stone and retrieved the stone. So so we require 2 laparoscopic, and we require 2 towers. 1 tower was for laparoscopic guidance, the other tower was for endoscopic view, while we were doing the procedure. So, and this is what the abdomen looks like after the procedure. The umbilical port was the optical port, and 3 other ports were the trocars for the laparoscopy, whereas the one behind the drain was the port that was used to access the kidney. So we used the drain through that, but rather than put the drain into the PCS, we put the drain in the pouch of Douglas, in the rectovesical pouch, for the drainage of any urine that might seep noticed that within 48 hours, the brain was not functioning and we put it out. And the patient did it. So that was the fluoroscopic view after the procedure. This was the stone retrieved. So this third case I want to illustrate because we had to do combined fluoroscopic and ultrasonographic guidance. So this is the scanogram. It's a huge stone, and then the stone, this RPG, the stone was obstructing both the middle and the lower pole infundibuli. So I had to do ultrasound guided puncture into the dilated middle pole, and then through my needle I pacified the system, and then this is what we got. We dilated over the needle, and we dilated into that tract, and then cleared the stone. So the stone retrieve was used to draw this pattern. And then the fourth case was a huge stone in a bifield system with multiple secondary stones. This one required 2 punctures, 2 tracts, and the stone was cleared. And we removed this next stone from the patient. And this is the last case I would like to illustrate. This case is one case that can be controversial because most people would not do the bilateral case at the same stage. So that as you grow in confidence and expertise with the procedure, there are some things we want to stretch. So in this patient, we did the first side, which went pretty well, no bleeding, and then so based on that, we had the confidence to try the other side, and it worked well. So since then, we've done about 6 bilateral cases, 3 in supine and 3 in prone. It's easier to do bilateral cases in prone position than in supine. So the complications, we had 1 case of colonic injury, 1 case of hydrothorax, 2 cases of urosepsis, and a case of excessive primary hemorrhage. So for the colonic injury, I hope you will please, and I hope it's clear. There's a colon there. Around the middle. If you see that colon, such a colon when you are puncturing, that is the colon. That is the colon. You will see that with the withdrawal of the needle, the colon keeps following the needle. And so this is the endoscopic view. So immediately I entered, I knew this wasn't the kidney, this was the colon. So how did we manage this? What I did was, the principle is to separate the tracts. So we did DJ staining for the unite tract, and then we left the point of entry opened for easy evacuation of any effluent. Thankfully, this patient's rectum, this patient's colon was not leading with feces, so we just left it open and put the patient on MPO. And the patient did very well without any sepsis or any problem. So, collateral damage from a broken scope, and this happened in a supracostal puncture with excessive torque when trying to get into a difficult cavity. And I noticed this was because of Richard Wolf, the way Richard Wolf's mini nephroscope is structured, so that the working channel is quite wide, which gives you an advantage with irrigation. But when you are talking in the vertical direction, the scope can really bend. So I learned a beta lesson so that when I'm trying to talk, I prefer to talk transversely rather than vertically. Because the weak point of the Richard Wolf mini nephroscope is actually in the vertical direction. So some of the innovations we have we have done is posterless procedures. After our initial procedures, we now do our full procedures. We now do them posterless, and without any problem in the patients. Sequential endoscopic combined intravenous surgery, what has been described in the literature previously, is endoscopic combined intravenous surgery. But when you are working in a setting where you don't have the luxury of 2 urologists, you are the only urologist where you have a nurse with you. So you can do sequential combined in a situation where after you have done the major work, antegrade, percutaneous, you can go a little bit while your nurse stays upstairs, and then you can then do complementary search for any residual story, and then pass it to a complement point where you go back and then pick it. So it's a bit cumbersome, but it's doable. So one of the reasons I also found split-leg positioning helpful, apart from the fact that it allows you retrograde access into the system, is that sometimes if you're dealing with a difficult to reach upper pole calculus, you can actually, rather than stay on the side, you can come in between the legs of the patient and you're able to pedal maneuver your scope into the upper pole and then achieve clearance. So the challenges of pioneering the PCNL program in the private hospital in developing countries are lack of mentorship, lack of infrastructure, lack of other professional support and infrastructure in case of complication, the initial reluctance of the patient to submit themselves during the the fear of failure due to its devastating effect on their reputation, the high cost profile and lack of insurance, reduces affordability with the consequence of this patient load. So, comparing these non-totos learning curve with the established fellowship in the major demerits are that the fellowship program is more focused and easily measurable, progress, and there is less likely catastrophic complication because it is in a structured environment where you have multiple layers of people who will help you through and also help to cover your mistakes. The merit of this model is that exposure to multiple talented and skillful teachers across the world, also to have a varied experience. So these are my references. Thank you.
Thank you very much. Sorry, we are run out of time. We move to the next presentation and the question at the end of the session. Thank you very much.
Next presenter, Dr. Sani Aminu, will be talking about biofeedback and relaxation to ease anxiety and pain during flexible systems.